Sekarang ni try nak
Oh, tengah situ. Tapi tengah sini lah.
oh tak boleh. Oh, okey.
Itu tanya.
Now we move on to second talk by Dr. Fairos Muthalib. She is senior consultant radiologist from Hospital Raja Perempuan Zainab II. Her main interest is in breast endocrine imaging. Without delay, I call upon Dr. Fairos to deliver her talk on current trends and issues in breast imaging.
Assalamualaikum warahmatullahi wabarakatuh and very good morning. So the task that I was given is regarding the current issues and trend in breast imaging. So the whole of the presentation will cover the ultrasound, digital mammogram, and also MRI in the breast imaging. So first of all, for the ultrasound is the screening and diagnostic tools. We do the screening in high-risk women with a dense breast and can detect additional ipsilateral disease in 40% and contralateral disease in 4%. And for diagnostic value, actually for the guidance biopsy and valuable in adjuvant with the mammogram to assess the morphology of the lesions and easy to perform and also non-radiation. However, there is a limitation for the ultrasound because it's time intensive and also depend on the operator and it is a low sensitivity for the DCIS. And for the mammogram actually to detect the the mammogram actually the primary imaging modality in the breast imaging for the early detection and diagnosis of the breast cancer. It is the only imaging modality proven to reduce the mortality from the breast cancer. One of the studies done from 1963 to 1988 combined data suggests mortality reduction is about 29 to 40%. And currently we have a digital mammogram. Actually, it's a major recent advance in mammography. It is markedly improved the contrast resolutions. Study has shown increase in the breast cancer detection in women with a dense breast, either pre-menopausal and age less than 50, and also decrease the mean glandular dose, whereby in a conventional mammogram, the radiation that be given to the both breasts is 3.7 milligarad compared to the digital mammogram actually 3.7 and conventional is a 4.7. So the increased efficiency of the acquisition, storage and post-processing of the image is better in the digital mammogram. However, there is a limitation in the mammogram because it is a dense breast, complex branch patterns. When there is overlapping structures, heterogeneous histology of the breast cancer, we can miss the sum of the occurred disease, and interpretive, we can miss the diagnosis, and there is no inclusion on the image because it depends on the operator. So it is also underestimate extent of disease, especially in the invasive lobular cancer, in DCSS, and also in when when it is incompletely includes the axilla. So for the MRI, actually is a well-established as imaging examination of the choice in evaluation of the silicone breast implants for rupture. Is rapidly evolved into a high valuable and clinically useful adjunctive imaging exams for breast cancer detection and diagnosis and also for the pre-operative planning. So the strengths of the MRI, because the morphology and the physiology assessments with the high sensitivity, most malignant lesions enhance following we give the contrast due to the tumor neurogenesis. The cross-sectional, because it is a cross-sectional, we can do in view of coronal, sagittal, and axial, so there is no overlap of structures, and ability to include the breast, chest wall, and axillary region. And this MRI is depends on the center, whereas there is a facilities of MRI. some of the center, although there is an MRI, there is no call for the breast, so we cannot perform the MRI. So we are lucky in Kota Baru because I fight, we got the call for the MRI for the breast, so we can do MRI breast. And cases from the from the Terengganu, they have to send to our HRPZ to do the MRI breast. Although there is MRI in Hospital Kuala Terengganu, but there is no call specific for the call specific for the breast. We cannot perform. They cannot perform the MRI breast. So there is a special breast issue that we, as a radiologist, we often face because especially when there is a breast reduction mammoplasty, and currently all patients want to do a cosmetic augmentation and also post-treatment reconstructions. So when we face this procedure, when we do mammogram or ultrasound, we face a difficulty in reporting because there is a limitation. So I will discuss about the issue. The first issue is the first issue is reduction in mammoplasty. Reduction mammoplasty is one of the most common plastic surgery produced in Europe and Western countries. So in Canada, you can see a lot of patients already done the reduction mammoplasty, about 28,000 patients. And in Turkey, about 264 cases in 5 years. However, in local Malaysia, we don't have any data available. And we can see in the Swiss, only a single Swiss academic center, 534 cases already done the reduction mammoplasty from 1990 to 2010. So this is imaging the mammogram. I hope the audience can see the image. So this is a mammogram that we do in a CC view. For the mammogram, for the each breast, we will do a two view. It's a cranial caudal. Why is say cranial caudal? Because we compress the breast from CC from the head to the toe, and this is a medial lateral oblique. Patient will be in position of MLO, and then we do the mammo. So we can see the mammogram. This is cranial caudal. This is a oblique. This is for the 30 years patient after reduction mammoplasty in a 60 years old woman. So this patient already done mammoplasty 30 years ago. So you can see, definitely you cannot see the nipple because the nipples, because the nipple is being elevated, it's not in profile. So and furthermore in the MLO, we cannot see the pectoralis muscle. See here because of the mammoplasty was done. So in fact, the breast is a higher and flatter in contour compared to the normal positions. So this is the suboptimal when we do a mammogram that we have to face when patient having a mammoplasty. So the findings, mammography findings after reduction mammoplasty, alteration of the breast counter, elevation of the nipple, displacement of the breast parenchyma, architecture distortion, skin thinning, and also retroareolar fibrotic band. So the second issue is regarding the breast augmentation. Silicone breast implants have been marketed in US since 1963. So the estimated prevalence of breast implants in the US is about 300,000 by 1988. Local Malaysian, we don't have any data. So there is no evidence of increased risk of breast cancer, no evidence of systemic disease. And also it's usually because patient having a breast augmentation, delay diagnosis in women with the augmentations. And local complication, usually the capsule within contracture, pain, disfigurement, serious infection, also implant rupture. So the efficacy of breast augmentation on the accuracy of mammogram, so it's decrease the sensitivity of skinny mammogram but does not decrease the false positive rate. This may interfere with interpretation but can be improved using breast implants displacement view. But this is there is a limitation. I will show you the next slide. So first of all, I will tell about the types of breast augmentation implants such as saline, structure saline, silicone, round, and gummy bear. The fat transfer breast augmentation, stem cell assisted, injectable filters to plump the bus is either saline, hyaluronic acid, collagen, and free silicone. It's either collagen, they can use the collagen mix of bovine, cadaveric, a lot of type of collagen. Injector filters are not a standard practice, but only used in the unusual cases of contour deformity after reconstruction. Mm, okay. This is a 60 years old a Chinese lady had a silicone implant 6 years ago. So for a 60 years old Chinese lady, definitely there is something wrong, because if a 60 years old a lady, usually the breast will be replaced with the fat replacement. It will be fat, fat. It is a normal what we call a normal growth of the breast. The breast will never dance until 60 years old. 60 years. See, definitely there is something wrong. And this patient having a silicone implant. So the breast is very dense. So it's very difficult for us as a radiologist to see any lesion because it can obscure the lesions. So, and when the view that a standard mammogram, this one, this is implant. We show to you this is implant. This is compression pedal. This is the films. So this is the breast. So this is implant. So the standard mammogram views are taken first. So the breast and implant are compressed with moderate force. We cannot give a standard force as we usually do in a standard mammogram because we can rupture the implant if you compress too hard. So another additional view that we can do actually is an image displacement mammography views as called a Eklund view, which are performed with the implant pushed against the chest wall. So the compression pedals is applied to the breast tissue which is pulled forward. But this is limitation that this cannot be done if the implant is in the subglandular. It is only can perform its implant is at the subpectoralis muscles. So not all implant with the implant we can perform with this view. So this is to show you the normal appearance of subpectoral silicone implant. You can see this silicone implant. So you can see a very dense, wide, very dense, well defined in the breast. This is definitely implant. So because it is a subpectoral silicone implant, so the implant can be pushed backward. So after that, we can take the image. We can see this is the after the implant is being pushed. This is the CC view and this is the MLO view. So with this view, if you didn't do the technique, so we can obviously we can miss any lesions, especially in the no man's line, no man's line of our Merck's son. We can miss a lesion over here. So when we already push the implant backward, we can see perfectly if there is any lesion in the both CC and MLO view. This is the type of implant that I tell you just now. So for the subglandular implant, 39 to 49% of breast tissue may be concealed. So we can miss because it's already obscured by the mass. But for the subpectoral, 9 to 28% breast tissue may be concealed. So we can also do the view for the for displace the implant backward. So this one another image in mammogram, this MLO. We can see a subpectoral saline breast implant. So this is the muscle, subpectoralis muscles. We can see the implant is here. So it doesn't obscure most of the breast tissue we can see. Compared to the subglandular silicone breast implant is almost obscured. We cannot see anything. Only limitation, we can see a minimal glandular tissue only. So we can miss any lesions over the implant. So for the next mammogram evaluations, we can see the implant contour for any deformity, herniation of rupture of implant, look for the presence of silicone outside the implant. So here, by right, this is the MLO view. By right, we can see the implant very nice. But here we can see the failed right saline breast implant. So the margin is irregular. This is because of the fail of the implant. It's either the implant is already ruptured, it's irregular. So this is the right breast, this is the left breast. So the left implants appears irregular. By right, the implants should be rounded shape, very nice margin. But here you cannot see identified the margin very clear with irregular and collapse a global increased density at the left breast at these regions. So this an ill-defined density seen superior to the left breast, maybe is because of the rupture of the implant. So the third evaluation of the memo to see any capsular contracture. Patient complain of painful hardening of the fibrous scar that forms around the breast implants. And the effects of capsular contracture is either little or no capsular contracture result in 30% of reduction in the area of visualized. Moderate of severe contracture result in a 50% of reduction. So the implant of contracture, by right, you can see a very nice implant here. This is a definite compared to this view, we can see a distortion of implant shape that may be squeezed, and also there is a calcification around the implant. So this is both a breast with the implant. This is RCC. This is left canopedal CC. This is right MLO. This one left MLO. You can see on the MLO, you can see the margin very nice here. But the left implant is a spherical in shapes compared to the right side, and the margin also is also classified. So this is another the implant is already contract. So it can develop also a thin layer of calcium in the pre-implant capsular tissue. So like this patient, bilateral medial lateral oblique for a patient who having a subglandular silicone cell gel implants, which are calcified. This is a white teeth here, is a calcification around the implant, and this one also calcification, very margin is calcification. The white is a calcification. So it is indicated of calcification adjacent to the fibrous capsule of the implant. So another evaluation that we noted during the mammogram is a fat injection in the breast that can calcify and mimic mass lesion, and it is not stable because a certain amount will be reabsorbed. So that like this patient, we are usually we encountered a lot of cases we encountered currently in the hospital Raja Perempuan Zainab. Is a silicone injection bilateral cranial caudal CC, this one in the CC, this one MLO. We can see a very a silicone injections with a eggshell calcification surrounding the granuloma to the breast, and it's extend to the axilla. This is a silicone injection. It's very dense breast. So if we proceed with the ultrasound, I show you the classified first. And this is the another Chinese lady with history of bilateral breast injection. We can say extensive opaque materials, like very dense nodules, of various size and shape occupied in the both breasts, extend to the axilla. So this in keeping with granulomatous classification of the silicone injection. So this one another patient, skinny mammogram, asymptomatic, 40 years old, Malay lady, no family history of breast cancer. We can see this is MLO view, this is CC view, a very dense. We can see a lot of rounded, various size and shapes occupied the both breasts. So if you don't have any experience with the silicone injection, you will say this is a mess. Uh, you you will say this is a mess. So definitely this is a silicone injection. So when we do the ultrasound for the silicone injection, actually it's a snowstorm's appearance. So we cannot see anything. It's like this a snowstorm appearance because the presence of free silicone droplets meets the breast tissue, giving a characteristic heterogeneous echogenic appearance. So this is the when we report a mammogram with a dense nodules of various type. Actually, this is calcified with a snowstorm appearance in ultrasound. This is definitely a silicone injection. See this collagen injection. You can see the nodule. So this is not a lesion. Actually, this is a nodule of injection of collagen. Don't misinterpret as a CA. So Some of the patient also do a breast augmentation with a autologous myocutaneous flap and bilateral mammogram when we do the craniocaudal and also or the this is CC, this one MLO view. You can see the fat necrosis. The fat is necrosis with dystrophic calcification here bilaterally. This is a fat necrosis because of the myocutaneous flap is become necrotic. So we also sometimes we also face with this mammogram. So the most issue apart from the augmentation of the breast that we usually face is a post-treatment reconstruction for the patient who are having a lumpectomy, white local excision, mastectomy, radical mastectomy, and also the breast reconstructive surgery. So because when the patient having this procedure, it will alteration of the breast contour, elevation and displacement of the nipple, displacement of the breast parenchyma, cause architecture distortion, skin thickening, retroareolar fibrinotic vein, disruption of the breast subareolar duct, and also fat necrosis. I will show the image. Okay. So this is 64 years old Chinese lady, had history of lumpectomy in 2007, presented in 2007 for a vague pain at the left breast. Patient having lumpectomy. Mammogram show a stromal distortion at the left inner quadrant, which is present in the on-compression view. However, when we do a serial ultrasound mammogram imaging, actually is in keeping with this one, in keeping with a scar tissue. So this one another patient who having a lumpectomy 5 years ago. So if you see this is the spot we do, we can say that it is like a mass with a speculated margin. Actually, this is a scar tissue. Don't misinterpret this is as a lesion. So that's why when we do a mammogram for this patient, you have to follow with the ultrasound because ultrasound will delete the scar tissue from the subcutaneous until the region of the excision. So this one, the patient who having an excision done and with a hook wire localization into 008. So this lesion are having a speculated region here, and hook wire was performed, and then we do the what localization. So and this patient follow up later. Patient develop a scar tissue. This one patient develop a scar tissue post follow up because of the post excision hook wire. And this one another patients who having a excision in the left breast lesion for the 20 years ago, and it is an asymmetrical dance of the breast, and also there is artificial distortion here and here. This is because of the post surgery. This is associated with a skin focused skin thickening at this region. So this patient who already done white local excision done in the left breast for 207 mammogram surveillance done show there is a small left breast compared to the right side, and also there is a nodular focus skin thickening here because of the post operation. So this is a patient who having a mass. You can see here a mass in 2012, a speculated soft tissue density mass in the left breast along the nipple line. So this is the lesion in the left upper of the quadrant. So removal of the lesions show the left breast is small. See the elevation and also the nipple retraction of the nipple on the left side with skin thickening, distortion of the left breast. This is the after the operation that we usually find when we do the screening for the surveillance of the mammogram. So this is the patient who having a bilateral skin sparing mastectomy. So we using the transverse abdominal muscles, bilateral with the flap, and both this is a CC and medial lateral oblique mammogram show a predominantly fat replacement with a minimal posterolateral located soft tissue density here. And on the left side on the left side due to muscle component and preoperative scarring. So this is when we facing when patient having bilateral skin sparing mastectomy after we do a follow up mammogram. I think this will be the end of the slide sessions. This the current and issue that I think that I can this that I think is for the surgeons that as a radiologist that we face, what is our difficulty when patient having a lot of implant or a lot of operation for the breast tissue. Okay, with that, thank you. Any question? Hmm. Soalan mana? The size of the MRI. First soalan. Can MRI detect invasive or in situ cancer in breast injected with silicone? What is the size that MRI? Actually, MRI is very sensitive to detect. I cannot tell you what is the size that MRI can detect because MRI there is no overlapping structures. That means less than 1 mm MRI can detect if there is an enhancement when we give the contrast. For the MRI to detect invasive or in situ cancer in breast injected with silicone, actually, when we do the MRI, we look at the pattern of enhancement. There is a classic enhancement of the MRI if it is a cancer. So it's either invasive or in situ, we cannot determine. It is depends on the HPE. So what we do when we inject the contrast to online the lesions, we can see an early uptake of the contrast within the lesion, and the wash up is very rapidly. So it's definitely this is a finding of a CA, because when we do the MRI breast, we do a dynamic scan when we give the contrast. So to differentiate invasive in situ, for my limited experience, usually we didn't see. We only see the pattern of enhancement. I think I can. I hope the Datuk Dr. Chong can understand my limitation. And so far, maybe we are not the center to do the MRI price so often. Actually, we got only in a 1 year 5 cases. Cases 3 or 4 5 cases we do the MRI. Because when you do the MRI breast, if it is after ultrasound and after mammogram, we do the mammogram, and after the we cannot determine whether this is a CA or not. That's why we proceed the MRI. So next question. What about higher? What about higher folic acid injection after pertanic and stuff? This one, we actually for Miss Maya, for injection of the silicone injection, actually for the mammogram, we cannot differentiate what type of the injection of the of injection of the silicone, because when they give the injection of the of the injection to the breast silicone injection, it give the mammogram will be giving a dance with a nodular of various size and shape. We don't know, actually we cannot determine the type of the injection of the silicone, but we do when we got the mammogram with a nodule of various size and shape, definitely this is a silicone injection. When we do a post ultrasound, we giving the appearance of snowstorm appearance. Is the best imaging for patient for mastectomy? Actually, the best imaging is still a memo. For Miss Suriza, the best imaging for patient post mastectomy with a tram flap, the best is still a mammogram. In augmentation with fillers recommendation, what are your choice for immediate surgery and for treatment? Actually, I prefer mammogram. I still prefer mammogram for the filler or silicone injection. See, mammogram is imaging is the best imaging. Mammogram is the best imaging, and then we proceed with ultrasound. How frequent? How frequent? What is the chronic inflammation induced by silicone cause a suspicious contrast engagement pattern? Enhancement, contrast enhancement pattern. Will the chronic inflammation induced by silicone cause the suspicious? Oh, so the chronic inflammations, if you give any chronic inflammation, when we give a contrast, the enhancement pattern is definitely different from the enhancement pattern caused by the CA, because the enhancement pattern will not take early uptake of the contrast. We can see a difference in enhancement pattern actually. But from my experience, usually in HP in HRPZ itself lah, maybe in other center I don't know, because we hardly see any patient having using a silicone to do to proceed with mammogram and also to do MRI. But usually my patient is a silicone injection rather than silicone by the fluid, or is because of silicone injection rather than maybe I'm not sure. I don't understand the question actually. Will the chronic inflammation induced by silicone cause the suspicious contrast enhancement pattern? Is it for MRI or what? This one, because in mammogram actually for my there is a two pattern of MRI. Oh, so MRI. Actually, I just now I tell you that MRI in the pattern of enhancement for inflammation and also for the CA is totally different. The enhancement for lesion in CA in MRI, it will give, because we do a dynamic, it will early uptake of the contrast and early washout. But for a contrast enhancement for inflammation or benign, it will delay in uptake of the contrast and delay in washout. That is a typical of we will do the evaluation. We will evaluate the lesion using a dynamic. So that the very good of MRI, we can know from the enhancement of pattern whether this is a malignant, this is inflammation, or this is a benign, because there is a difference in the pattern of the graph. Is it there any role of CEDM? CEDM what? CEDM for patient with post implant scarring. CEDM apa? Is it there any role for patient post? Oh, post implant scarring. Actually, before it depends your radiologist and your center. If your radiologist has a very long experience for post implant scarring, definitely we can see very clear in ultrasound, also in mammogram. For contrast enhancement, when that means we use a thermosynthesis. Some thermosynthesis we can give contrast. When we give a contrast enhancement in thermosynthesis, definitely we can differentiate the implant scarring and also the CA, because the enhancement pattern is like an MRI is can evaluate, but not all center having this contrast enhancement, although they got the thermosynthesis, like in in Kelantan state, we got the thermosynthesis of chloride, but we don't have any we don't have any the what we call the software to do to give the contrast and then we evaluate the contrast as a pattern, because it's very expensive. So most of the hospital, I don't know, because in KKM, I think Colacras is the third hospital having a thermosynthesis mammogram. So it's quite expensive and we cannot afford to buy the enhancement pattern to give the enhancement. I don't know about the KL. I think KL they got the thermosynthesis, if I'm not mistaken, in GHKL. But I don't know whether they're having the software to give the contrast and then to analyze the enhancement pattern. But definitely we can differentiate, because the implant scarring is totally, there is no enhancement compared to the malignant. So HKL we do have CEDM. So if you got the CDM, actually you if there is a contrast enhancement, you can evaluate.
Thank you very much, Dr. Fairos, for a very interesting talk. We will have a tea break session for around 20 minutes and come back around 10:45. Just information, Amit has a cool features of social launch. This social launch is available only when the session is not live or during the networking break. While you have a break, you can make a conversation as ice breaking session or to meet an old friends in this social launch. We will show you a video how to use it. Thank you.
A format that lets you host vibrant and lively conferences virtually. Features like the reception, sessions, lounge, and arena of AirMeet give a grand conference experience to your participants, speakers, sponsors, and exhibitors. The lounge is a one-of-a-kind interaction area wherein participants can meet new people and build meaningful connections. This can be done either through speed one-on-one networking or group conversations at the virtual tables. Speed networking automatically matches one participant with another and allows them to network with people one-on-one. This is a great icebreaker and conversation enabler for your participants. Virtual tables are like tables at a ballroom that allows participants to get together in groups and have relevant and meaningful conversations over video. You can meet the right people with the help of the bio and seamlessly switch between tables to have interesting conversations. Make meaningful connections and expand your network with AirMeet.